Hello, my name is June Klein-Bacon, and I am a Brain Injury Project Manager with the Brain Injury Alliance of Iowa. A quick disclosure as we get started today. This content is from the Brain Injury Alliance of Iowa and funded in part through the Brain Injury Services Program of Iowa through Contract 5887BI06 with the Department of Public Health, and the contents are the sole responsibilities of its authors and does not necessarily represent the official views of IDPH or DHHS. Today we will be taking some time to discuss a review of changes and challenges that can occur with brain injury, which likely will be an overview for most of you. We will talk about advisement for screening consideration for brain injury in your respective experiences, and a discussion of brain injury assessments. In generalities, the public is hearing more about brain injury, particularly from the sports arena, filtering into the development of public policy around brain injury, particularly mild brain injury, better known as concussion. Our military, where we have heard about brain injury being caused over the last decades with such a significant rate, is considered the signature injury of recent conflicts. And from advisory and advocacy groups like ours, and of course, family and individuals experiencing brain injury every day. So what does this mean? Technology to save people has not kept up to manage the issues individuals experience as a result of brain injury. What are those results? We hear about high-profile athletes sharing their stories. We're seeing lawsuits on a national scale as well as locally here in Iowa. We've seen concussion laws and the proliferation of sports-related concussion research and law changes across the country. In Iowa, for example, we've seen concussion laws that were established in 2011 and updated in 2018. In the military, we saw armor improvements, and data is showing us that more and more people are surviving a variety of accidents, crashes, and other events. But as you know, more people are living with brain injury as a result. And as you know, being survivors, family members, and caregivers affected by brain injury is not something that you may have thought about until it was the only thing that you've thought about. Our brain is interconnected. While a simplified description and location of injury can tell us a great deal about someone's experience, as you know, it is imperative to recognize that brain injury may disrupt a variety of functions that can include cognitive, emotional, behavioral, and physical that can all be quite complex. It may be helpful not only for you as a survivor or family member to understand the physiology of a person's brain injury, but to understand that assessors or case managers may not have the full understanding of these complex details. Premature efforts to return to the old normal can result in secondary conditions. In addition to not being connected to information, services, and supports, can lead to scenarios in which individuals find themselves accessing inappropriate or incomplete treatment options to address their needs, or none at all, landing them in what we may see as marginalized sections of society. Statistics that we are learning from the mental health community, criminal justice, and TBI model systems are that there is a 34 to 49% prevalence rate of psychiatric conditions among brain injury survivors. 50% of brain injury survivors continue to abuse alcohol and/or other drugs. 60% of survivors 60% of those incarcerated have sustained at least one traumatic brain injury prior to incarceration. And we've also learned that there's a 72% prevalence rate for individuals that experience one severe mental illness, a substance abuse diagnosis, have also had at least one traumatic brain injury. As a community, we recognize that brain injury screening is not systematic across disciplines, and as identified by a wide range of statistics, we recognize that rarely does an individual entering a system of care with a single condition or concern. That is why we find it imperative that we collaborate across systems to encourage brain injury screening during the intake process and to lean into colleagues in their fields of expertise for case consultation in building quality treatment and service plans. Brain injury symptoms are not always immediately evident, and the general public has limited knowledge about the diagnosis. Brain injuries can cause increased susceptibility to multi-occurring conditions, including those mental health diagnoses and substance use disorders that we spoke about just a moment ago. Gaps in brain injury identification were identified by a screening project completed by the Iowa Department of Public Health at a community mental health center, and it showed 57% of those that screened positive for brain injury. Another project completed in 2014 at the Waterloo Women's Center for Change produced 67% screening positive for possible brain injury. Once a person has identified they have a positive screening, then it's important to communicate what that means. Again, this is not a clinical diagnosis, but it does provide a team with an opportunity to evaluate if a clinical diagnosis is necessary, to discuss with appropriate medical personnel. In addition to that, information may provide the support team and the client with valuable information on how to build a service plan that's unique to the concerns that they have. It may also allow for opportunities for referrals for additional assessments to occur. So let's talk a little bit about assessments. Levels of assessments have different purposes. When reviewing the types of assessment, it is important to understand which level of an assessment an individual is attempting to access and why. A level 1 example would be a neuropsychological exam. These are typically heard of as the gold standard to identify clinical eligibility and identify diagnostic criteria. Functional assessments, or level 2 assessments, do not provide a diagnosis, but provide the team with valuable information around service needs in a variety of areas. The only valid and reliable tested brain injury functional assessment to date is the Mayo Portland Adaptability Inventory. These have now been implemented by the state of Iowa for the Brain Injury Waiver as a supplement tool to the SIS. Level 3 assessments are service plan assessments, which generally are left to the discretion of agencies and state programs and may not be specific to disability types or needs and do not provide clinical or diagnostic information. The Brain Injury Alliance, international colleagues, and now Iowa identify the Mayo Portland Adaptability Inventory as a functional assessment that is validated for individuals with brain injury. This assessment is designed to assist in clinical evaluation following acquired brain injury, assist in the evaluation of rehabilitation programs, assess obstacles to community integration, and this assessment also evaluates cognitive, emotional, behavioral, social, and physical changes following a brain injury and how they're impacting individuals' interaction with their community and day-to-day living. The Mayo Portland is a nationally accepted standard among brain injury assessments to provide outcome data. And as we know, most, if not all, payers, including insurance companies and governmental agencies, are requiring assessments as well as outcome data for programming. The Brain Injury Alliance of Iowa has put together this particular webinar to support individuals who experience brain injury, family, and caregivers to gain a sense of what the supplemental assessment for the state of Iowa currently is and how it's used for the brain injury waiver assessment. A better grasp of the assessment should support accurate and quality assessment data, in addition to providing you and a potential service planning team a greater sense of functional needs to support a more effective service plan. I would note this particular assessment was authored by Dr. Malik and Dr. Lizak, who give extensive nods to collaborators across the nation who assisted in review, providing feedback and outcome data for further development and study of this assessment. The Mayo Portland is endorsed by nationally recognized organizations, and it is on its 4th revision. Ratings are tested and shown to be valid and reliable in multiple ways. This assessment reviews the most frequently affected areas of acquired brain injury that are considered by rehabilitation planning or other clinical interventions that include a range of physical, cognitive, emotional, behavioral, and social barriers that individuals may encounter following a brain injury. The development of this assessment makes it possible for it to be completed by a professional staff, significant others, and individuals who experience brain injury. Research established it is an available manual shows the reliability of completion of those rater groups. A group consensus evaluation with a staff member familiar or a family member familiar with the assessment is the most reliable and accurate way to complete this assessment. As we review the subscales, it is helpful to think about how each function is rated. In general, the screen shows how each function is rated with a 0 to a 4 on a Likert scale, starting with 0, indicating that there are no problems and no adaptive devices being used. A 1 indicates that there is a mild problem, but it does not interfere with activities. A 1 may also indicate that assistive devices or medication may be used to manage the function. A score of a 2 indicates a mild problem that may interfere with activities up to 24% of the time, indicating that 76% of the time, the person is able to manage barriers or adapt to functional challenges. In a similar fashion, a 3 indicates a moderate problem in the functional area, interfering with activity 25 to 75% of the time. And lastly, a score of 4 would indicate the participant's functional impairment is severe, interfering with activity 76 to 100% of the time, and rarely is a person able to adapt. So if we take a look at each index, and there are 3, and the topics that are covered, we can see in the ability index, sensory, motor, cognitive abilities are reviewed. In detail, each component is scored for mobility, use of hands, vision, audiation, motor speech, communication, attention or concentration, memory, fund of information, novel problem solving, visuospatial abilities, and dizziness. For our purposes today, we can look at one component of each of our subscales. So if we take a look at memory as an item by itself, the heading provides us a guide to discover the client's abilities to learn and recall new information in relation to the skill of memory or the function of memory. The assessment provides the assessor and the team with guided scoring. You will note on the slide each area has an ellipses for the purpose of noting that this is an abbreviated comment on what would be provided in the full manual for review. So here we can see that a score of 0 in memory would indicate that a person has normal learning and delayed recall demonstration. When available, the assessor should and can review neuropsychometric testing and make note of the client's age in comparison for normal development compared to the impact of the problem. As the scale progresses, we see that memory impairment increases in the interferences with activities in day-to-day life, up to a score of 4, which includes learning information and retention being very limited, creating an environment where self-directed compensation techniques and strategies would not be possible because of the memory impairment. So if we move to look at the items that are covered in the adjustment index, this includes mood, interpersonal interactions, and family interactions. In detail, each component is scored for anxiety, depression, irritability, anger, aggression, pain and headache, fatigue, sensitivity to mild symptoms, inappropriate social interaction, impaired self-awareness, family or significant relationship impacts, initiation, social contact, and leisure or recreational activity. Again, for our purposes today, we'll take a look at one component of this subscale. So if we look at fatigue, which is common among those recovering from brain injury, we take a look at the manual to lead a discussion on how fatigue, feeling tired, low in energy, fatigability, feeling low in mental or physical energy after relatively low level of mental or physical activity can occur. As with memory, the assessment provides the assessor and the team with guided scoring for every item. Again, you will note each slide has an ellipses for the purpose of noting that this is an abbreviated comment on what is being provided here versus what's in the manual. So here we can see that a score of 0 in fatigue would indicate that a person has no significant fatigue reported. With a rating of 1, this person would be able to compensate with scheduled rest breaks. For example, up to a score of 4, where the individual's fatigue may be totally or almost totally disabling and remains inactive most of the time due to fatigue levels. The participation index, which includes social contacts, initiation, money management, and residence, in detail, each component is scored for self-care, residence, transportation, work or school attendance, and money management. You may note that initiation, social contact, and leisure recreational activities are in both the adjustment and the participation indexes. While in the final scoring, there is opportunity to view these indices individually, the total score accounts for it being labeled twice. In our last subscale, we take a look at residence. The responsibilities of independent living and homemaking, such as meal preparation, home repairs, maintenance, medication management, and personal health maintenance. Because other items cover basic hygiene and money management, that's not included here. There's additional information in the manual to ensure discussion regarding age, appropriate scoring, as well as the support of supervision rating scale can be utilized. While repetitive, I do want to ensure again that I mention, as with the first two reviewed, the assessment provides the assessor and the team with guided scoring for every item. You will note on the slide, each area has an ellipses for the purpose of noting that this is an abbreviated comment on what is compared to what is actually provided in the manual for review. So here we can see that the score of 0 would indicate the client is capable of living independently, either alone or with others, and does not receive supervision or assistance from others in order to perform basic instrumental activities of daily living, and perform these at an acceptable level. Moving up the scale increases concern around safety or ability to perform or complete tasks, providing notations for the assessor to indicate how much assistance or supervision is needed, from none to virtually all the time. There are some modifications to be considered when completing the assessment on youth. A score of 0 would be automatically applied to areas where age is inappropriate for that child. For functions that would be inappropriate for that child. For physical and cognitive functions, the rater would need to consider normal development processes for children the same age. If functioning is not at a normal level expected for their age, scores 1 to 4 are given depending on the impact of the challenge for that specific criteria. There are 4 specific areas that need to be modified according to age of youth. First, residence. Independent living is expected to be possible at age 18. Second, driving should only be scored for youth that are over the legal age for driving. Fund of information should only be scored for children that are attending school or who have finished school. And lastly, school or work attendance should only be scored for children attending school or who are working. The primary role would be scored. Other considerations are that normal gait should be assumed from age 2 for mobility, normal speech achieved by 2 years old with clear articulation by 4. Pain would be best assessed after 2 years of age, and alcohol use should only be scored according to the legal drinking age. Use below the legal drinking age should be considered problematic and rated on severity of abuse or dependency. Mayo Portland Adaptability Inventory for user qualifications indicate that the assessment can be completed by people with brain injury, significant others, medical or rehab professionals, as well as other designated observers who know the individual well. Assessors should have a professional who is experienced with the Mayo Portland Adaptability Inventory review rater guidelines prior to making ratings and be available to answer questions. In clinical practices, comparisons among ratings can offer information about various perspectives and offer effective rehab planning, as well as reveal subtle problem areas. Scoring and interpretation require professional training and experience. Ideally, professionals with training in testing and measurements would be available to clinical teams for clinical evaluation. The Mayo Portland Adaptability Inventory Manual provides guidelines for rating and scoring that include those modifications for children and adolescents and consideration for normal physical and cognitive development based on age. And while the Mayo Portland is designed to represent the symptoms of brain injury, the first 29 items should reflect the current status of the person being rated, whether or not the conditions other than brain injury contribute to restrictions in ability, activity, or social participation. As if there are pre-existing or multi-occurring conditions that contribute to those ratings will be identified in the inventory. A scale is provided for the assessor to support the development of a score in each area in the manual with details on how to provide a rating. Again, an assessor should be familiar with the rating scale and content to support recommendations based on conversation, motivational interviewing, or questions that may come from team members in developing a consensus rating. The Brain Injury Alliance of Iowa utilizes the T-score, a national sample staff rating when completing assessments. Utilizing the manual, we see the T-score reference guide compares scores to other people with acquired brain injury. The score of 30 and below represents relatively good outcomes. 30 to 50 suggests mild limitations, and scores of 60 and above suggest severe limitations. With T-score reference guide comparing other people with acquired brain injury, scores between 40 and 60 would be considered average or typical of people involved in outpatient, community-based, or residential rehabilitation following brain injury. Scores in the 40 to 50 range may be considered in the mild to moderate range of overall severity compared to 50 and over in the moderate to severe range. Once scores are developed, there are national data sets that can provide teams with suggestions of where that person's limitations may fall in comparison, suggestions on limitations and outcomes as noted just before. And these can be outlined in each subscale, ability, adjustment, and participation, and in addition to an overall score. However, we believe it is imperative that the team continues to value person-centered service planning and utilize the results as a tool to drive service planning. Another value that is created by the team participation is within each evaluated area, the discussion points may provide supporting documentation for service planning to create more effective services and supports that address specific barriers based on the individual with a brain injury. As we recognize and understand that brain injury symptoms are not always immediately evident, and our clients may not always be aware of the barriers they are experiencing as a result of brain injury, it becomes even more powerful when those in the service field can coordinate an effective treatment plan with multidisciplinary teams of providers that have experience and knowledge about various disciplines. And so again, The Mayo Portland is a nationally accepted standard among brain injury assessments to provide outcome data, and as we noted, more entities are requiring assessments as well as outcome data for their programming. The Brain Injury Alliance of Iowa put this particular webinar together to support you to gain a sense of supplemental assessment the state of Iowa currently uses for its brain injury waiver assessments. Our hope is that a better grasp of the assessment should support a more accurate and quality assessment, providing data that would also provide you with a potential service planning for the team with a greater sense of functional needs that would in turn support a more effective service plan. And with that, I would like to thank you for attending our session today, and we will use this time to take questions.